Thank you very much to the organisers for the invitation and the generous support that allowed me to be here today. It's the custom in Australia to open meetings with an acknowledgement of the traditional owners of the land on which the meeting is taking place, and to pay respects to elders past and present, and I'd like to extend the same to the Aboriginal communities of this area. What I'm going to present is very different to what you've seen earlier today, because I'm drawing mostly on qualitative research, and I will be using strong language because one of the important conventions in qualitative research is to be true to the data that you've collected from participants and use their own words. And I think in this case it's particularly important to use their language because the depth of passion and feeling that people talk about their experiences with hepatitis C and other cares is very important to the argument I'm going to make. So to kick it off in this very broad topic of social issues in hepatitis C care and treatment, I've thrown up a very detailed slide of which I want you to take no notice whatsoever. This is a summary of barriers to hepatitis C care at patient, provider and systems levels. And we could spend time today continuing to add to the list because I'm sure it's not exhaustive, or we could spend time recategorising some of the issues. But I don't think that's very helpful because potentially this list is never ending and it doesn't give us a clear way forward. What's the most effective way to address these barriers? What I do want to spend the time I've got allocated today is to take a couple of steps up to look at a kind of a helicopter view, draw on some ideas and concepts from social theory to help tie together this complexity. So I'm going to be speaking about stigma, social exclusion, symbolic violence, structural violence, and in particular trust. And I'll explain all of these as we go. Now, the take-home message, trust is kind of an airy-fairy, waffly word, but there is a very nice literature around trust. And the take-home message of that literature is that trust between patient and health provider is essential for effective therapeutic encounters. I'm sure that's what we want, effective therapeutic encounters. But what I want to argue today is that besides all the other elements of trust, these notions of stigma, social exclusion, etc., are particularly relevant for people with hepatitis C and those with a history of injecting drug use. So after going through that, I want to briefly turn to three models of care that I'm familiar with because we've worked on the evaluation of them to show that how some healthcare models have responded to these notions of trust. Even though it may not have been part of their setup, they've worked in ways to build trust between themselves and clients. So the questions we're going to ask today, is trust important? And hopefully I can convince you that it is. Think about the things that shape trust. There's stigma, social exclusion and so on, and as well as a few other things, and then how to build trust in health services. And the questions I want to pose to those who run services in the audience are, do clients trust your service and how would you know? What does trust or mistrust look like in the context of your work? What does it matter? What would clients miss out on if they didn't trust your service and didn't engage with it or didn't engage fully? And how could you build trust or demonstrate trustworthiness? And what about those services you work with that might be on the outside, pathology, pharmacy, so on? Do clients trust those? And if they don't, what might they be missing out on there? And how could you work to build clients' trust in those external but important services? So let's jump straight in. Stigma is an overwhelming finding in the area of hepatitis C, both related to that infection and its associations with injecting drug use. And I've chosen a quote from a study a decade old, but we could walk into any city in a developed country and get this and much more still today. It's kind of disheartening what hasn't changed in over a decade. So this person from Melbourne in Australia says, "I know how I answer the doctor's question is going to determine how I get treated in this town. I could lie and get treated well, or I could tell the truth and get treated like shit. So in answer to the question how I acquired it," and you could argue that question may not need to be asked, of course, the person told the truth, decided to tell the truth and said, "through intravenous drug use." And the doctor's whole demeanour towards me completely changed. Now this is kind of a mild quote to get you warmed up because we have a collection of enormously just distressing narratives from people who've been refused service, who've been turned away from places, told to get out, who've had their status inappropriately disclosed to many people. This is the very tip of the iceberg. The decision to talk about hepatitis C, the decision to turn up at hepatitis C service is not one that is taken lightly by many people. Right, let's jump a bit further in. This gets us closer to the real guts of the issue. Social exclusion and trust. So this is Drew, a client from the Ethos Project, which I'll talk more about later. So Drew says, people have got to understand we have big trust issues. We've been fucked over all our lives. That's why most of us are addicts, because we've had bad, not so much bad upbringing, but bad experiences. Experiences of violence in the family, alcoholism, and all that sort of thing. Now, by presenting this quote, I'm not at all making a simple deterministic argument between bad childhood experiences and later drug dependence in life. That equation just isn't simple and linear. But we do know from the social determinants of health literature that experiences early in life such as this do close off doors of opportunity, do limit people's access or opportunities to education, employment, housing, and so on. We also know that the harms associated with drug use are multi-directional, not just things that precede it, but things that follow drug use in relation to its prohibition and then criminalisation, incarcerations, and so on. It's a complex multi-directional field. Stigma, social exclusion. The next one, symbolic violence. It may be a term that people haven't heard of before, and it's a big sociological term. So to reduce it in a couple of minutes is the internalisation of the social messages of what's good and what's bad. And these are messages that people who inject drugs of hepatitis C have heard for years and perhaps decades. So to illustrate this first quote comes from work by Tim Rhodes in London in the UK. And this person had tried for 10 years unsuccessfully to get hepatitis C treatment. And this was his unpacking of that experience. The Hep C doctor was literally saying, look, you're never going to be treated here. I wasn't a productive member of society, that's what I felt. I wasn't someone who was going to make a difference to society. He had more important patients than me. With 10 years, this man kept turning up at a clinic. You have to admire the resilience in the face of these messages. Now, these social messages are also seen by staff, and this quote, second quote, comes from a staff member of an Ethos project talking about methadone services, actually. So she says, as far as the actual dosing sites, it's pretty appalling. It's like you're a cow going into slaughter, so a dehumanising message here even. You've got this line in the morning, there's no cover if it's raining. Winter, it's freezing, not as freezing as here, but freezing for there. There's winds, there's no protection. The atmosphere is very punitive. It wouldn't be tolerated for any other illness. Now, people who inject drugs are not blind or stupid. They feel these messages, and sometimes very deeply, and incorporate them into their senses of self-worth and believe that they may not be as worthy as people with other conditions for appropriate care. These are the kinds of things that come with someone when they consider turning up for hepatitis C treatment and make that decision very difficult. Structural violence, another big concept. And these are the forces in our society, in our institutions, that prevent people from keeping and meeting their basic needs. Now, this is a long quote, and I'm not going to go through all of it because it's got some great language in there, as you'll see. But it's from Sione Crawford, who's a service user in Sydney, Australia. And he's written this wonderful commentary just published in the International Journal of Drug Policy. And in fact, it's a free ebook on the IJDP website. You can go and download the whole special issue on opioid pharmacotherapy, just as a plug, because I'm a guest editor of that issue. So Sione talks about the staff at his methadone service being behind bulletproof glass. Then he goes on to describe the myriad of things that make this environment very tense, very frustrating. Things are always going wrong. People are being called out for ridiculous urine testings. And then all of a sudden something happens and that tips over to boiling point. And then there's someone yelling. And if you yell, you get issued a warning. And if you get enough warnings, you may be thrown off the methadone program, therefore unable to meet your basic needs, an instance of structural violence. But Sione ends this section saying, but how do you communicate with someone behind bulletproof glass without shouting? How do you do that? So in this instance, the whole setup here is to reproduce those stereotypes of people who are on methadone, that they're unpredictable, that they do shout. But then the physical location, the rules and procedures of this clinic produce those stereotypes. Moving to trust, and I'm going to tie all these things together in a minute. Now, this quote pulls out some of the usual things that are talked about in the literature on trust, that it's based on a notion of confidentiality, that the person feels the health worker and the system will act in their best interests, and they'll do this honestly. But Hannah, a peer worker, troubles all that And she says, people in the health system can say, everything you're saying here is confidential. And as soon as they leave the room, they've got you. You've already signed 1 million pieces of paper where you've given informed consent, which means that it's gone to everyone that needs to, I've just lost myself, everyone that needs to be told. And it doesn't, we all know that it doesn't stay in the room. And it's just those lies that are being institutionalised. Years of rehab, detox, treatment. People don't believe the lies anymore, so they don't put complete trust in the health department. Now, this is a complex quote, but one of the important things I think Hannah is saying is that clients don't necessarily see the difference between this service and that service and this service after years of engaging and being fed what they perceive as institutionalised lies, that this health system might be a mistrusted whole rather than a series of segments that people have different relationships with. The notion of the system is further pulled out in Barbara's quote here, where she says, I can trust the methadone caseworker to a point. I can go and have a cry if I feel upset about something, but I'm not going to tell her the details of something because I don't know if it's going to get mentioned at a staff meeting. And the thing is with the staff and the system is they all back each other's back. And I think the message here, which she doesn't say, is that they don't back my back. They look after themselves and not me. This might be very harsh information for people to hear, but bear with me, we'll get to something more positive soon. Here's Rick, who's an NSP client, in which needle and syringe programs in which he talks about having a lot of trust in those programs, but then he compares that to his experience with his drug and alcohol counsellor, to whom he doesn't share information. So he says, I just don't say things to my drug and alcohol counsellor. I work. I have 4 takeaway doses of methadone a week and I'm relatively stable. I don't go up and down. I use drugs, but on a consistent level. I take care of my health, whereas all it would take was for my OST prescriber to know that I was using, and therefore I wouldn't have any takeaways, and therefore I wouldn't have any job, therefore I wouldn't have any income, therefore I would lose my mortgage, therefore I'd lose my house. And just because I was honest and said that I've been using, that's a hell of a fucking consequence for just trusting somebody enough to say, yeah, I had a shot last week. I mean, this is a huge deal for Rick's life, but he feels would not be shared by the drug and alcohol counsellor, who'd be much more focused on this use of drugs rather than the other much more important for Rick aspects of income, housing, mortgage, so on. So what does all that have to do with hepatitis C care? Glad you asked. So the usual components of trust we see here, notions of confidentiality, competence, best interest, honesty, they're all in these data I've been talking about. But what I think is much more important and isn't explored that much in the literature is this notion of global trust. And I think this is where all these social forces are wrapped up, the cumulative effects of stigma, social exclusion, and so on. And unfortunately, to most of us in the room as white, middle-class, educated professionals, these are socially and culturally invisible forces. We are not the targets of exclusion, symbolic violence, structural violence, and indeed sometimes we are the unwitting perpetrators of them. It's difficult then, what can individual clinicians and clinics do to work against these socially, culturally invisible and sometimes internalised forces? Important, firstly, not to be paralysed by what I've just said, but to look to the literature which says that services that are actively anti-discriminatory and non-stigmatising can change expectations of future interactions. So let's move forward. I'm going to talk briefly about 3 models that I'm aware of because we've done evaluation work on them. The first ran in New South Wales, where general practitioners were trained firstly to do shared care with specialists and then later to do initiation of Hep C care in the community setting. The second is Ethos, which is 9 clinics usually running methadone or other opiate substitution treatments, had included with them a Hep C care, and those 9 clinics were pretty a broad range of community-based organisations. And the third came from New Zealand in Christchurch, which was a standalone, newly set up, nurse-led hepatitis C community clinic, also with GP and social worker access. And interestingly, this Christchurch clinic was auspiced by their needle exchange program and not by a tertiary service. So firstly, recognising trust as a resource. The first quote comes from a patient in that first one where GPs were trained to prescribe Hep C treatment. And in and of itself, it's a bit of a thin quote, but I'll flesh it out. So this person says, I think the GP is probably going to understand your problems a lot more than some stranger in a hospital. Now, we could dismiss that quote. Yep, knows the GP better than he knows the doctor in the hospital. Fair enough. But what I think we need to add here is this notion of symbolic violence and understandings of self-worth, and it's fleshed out a bit more by Mick from the Ethos Project. And of course, these are all pseudonyms I've been using here. People, they're out of their environment. Some people who don't have a very polished and strengthened and self-confident opinion of themselves. They don't like to go out and discover things and head on into new territory. So the trust that clients already have in existing services, places where they already go, is a resource to be used. How can that be harnessed for providing them with additional services? This is a long quote from Anthea, a staff member, and she talks about a number of things: being able to provide practical assistance, being able to work to the best interests of her clients. So she says, I spent hours in the methadone dosing line trying to engage people. At first might have absolutely nothing at all to do with Hep C. How's your kids, broken foot, what's your nits, scabby feet, sexual health. Things like that really, really make a difference in developing a trust. To establish that I do have information and I don't think less of people for whatever they're talking about. And once you've established that relationship, the rest is easy, once they know you. And the word of mouth is, when we have new people, the people who are already here will say that I'm okay to talk to. A very ringing endorsement. This notion of inclusion, of working to the patient's best interest, is also highlighted here by Tracy. We loved Tracy as a participant. She was very articulate. And she says, it was nice to know that somebody actually looked out for Tracy, not just methadone Tracy. And they took time out to realise that there was something more than just me coming to get methadone. I had lots of issues, and the Hep C clinician helped me work towards hepatitis C treatment. Just a few more quotes before I tie this lot up. This is a quote from Alvin from the Christchurch Clinic in New Zealand. And this takes inclusion to a next step, I think. And he says, the clinic staff are understanding. They didn't look down on me. They talked me through it, supported me, showed me where to go. They were helpful, they were understanding, they weren't judgmental. They informed me about what's happening, and I like going there because I feel welcomed and helped. I feel I'm taken care of, whereas going to my GP was something I just dreaded. The last series of quotes here is about symbolic violence. And we had that quote from the staff member before talking about cows going into slaughter. And here's Remy on a similar vein in that top quote, talking about how poor methadone service provision is. It's methadone service users, they're the end of the food chain. There's no money in drug and alcohol. And again, these are messages that people who attend those services are not blind to. They're not seen as important. We in OST do not offer the best service. It's just dosing people, getting them through from crisis to crisis is how we bounce. And then Remy reflects on the change when hepatitis C services were included in that organisation as part of the Ethos Project. Well, someone comes in and pays them that bit of attention. It's like, well, hang on, I am worth this, I am worthwhile, my health is important. Doesn't matter how I contracted Hep C. But someone's given a damn about me and my health. It's not that stigma of you're on methadone, so you're not worth it. It's, you are worth this. Right, so here's what I see as a non-clinician, the strategies to build inclusive, non-discriminatory and trustworthy services, reflecting on all these notions of stigma, social exclusion and so on. At personal level, that staff are able to operate with their clients without judgment, that they're able to demonstrate and communicate issues of confidentiality and boundaries. Your service may not have been the one to put up the bulletproof glass, but you have to wear the mistrust of service users who feel that continuing fraught nature of entering into services. You need to, the staff should be able to acknowledge issues that are important to the client's best interests and not those that are on the services agenda, not only those. At the organisational level, find ways for staff and clients to interact in ways that are outside of the usual clinical behavioural script. Find ways to intervene on issues that are important to the clients and not just those that are important for the service. Undertake a critical review. Are there deep clashes between what are the best interests of the clients and what are the policies of the clinic? What about peer programs? Can they do some of the work that your service can't? And of course, those peer services need to be appropriately resourced. The issues of confidentiality are embedded within policies and practices of the clinic so that staff can communicate them and demonstrate them with clients. Acknowledging that power inequalities do exist between staff and clients and that mistrust may also exist, and asking clients what will work to start the conversation about those. At the systems level, developing partnerships with agencies that could do some work for your clients that your service may not be able to meet their best interests, to meet their needs. Find allies and promoters to champion your system and to explain its difference. Understand the relationship your clients have with other services that are important to yours. And of course, until today, I didn't realise how big an issue of a cost was for people with hepatitis C seeking treatment in this country. It's different in Australia, and seeking to minimise cost issues seems to be a bit of an important thing. So a final comment. The literature around trust tells us that it is important for better service outcomes, therefore important at an instrumental level. So it's very important to consider how to maximise the potential of new treatments. It's an exciting time in hepatitis C care and treatment, but build it and they may not come. Have to understand what are the factors that push and pull people towards hepatitis C treatment. From these data and many more, being able to trust a service is a remarkable event for someone who injects drugs and for some people who live with hepatitis C. That's pretty damning and should be a factor for a shame in our health service communities. But trying to do something about that instrumentally to build better service outcomes is an important thing, but much more important is that a service recognises the rights of people to access services and maintain their health without fear of repercussion. I'd like to acknowledge my colleagues and funders and participants in all the studies I've drawn on and my contact details, including my Twitter handle. I've just got excited about Twitter. I've been tweeting about this meeting, but my phone's died, so there'll be more tonight. Just to rub it in a bit, this is the final weekend of the Sydney winter. My kids on our local beach, and to be fair, one of them is wearing a long sleeve t-shirt. But if this appeals and you'd like to continue the conversation about hepatitis C, please receive our warm welcome to join us in Manly Beach, October 2015 for the 4th International Symposium on Hepatitis C in Substance Users. Thank you.
Thank you very much. We'll have one quick question. Jordan.
Take the prerogative. Thanks, Carla, for coming so far and for giving us some really interesting insights. One thing, I guess, as a healthcare provider who probably, as you pointed out, doesn't come from a community where many of these things are familiar to me. What kind of advice can you give to clinicians and people who aren't familiar with this to try to make sure that we know what we think we're doing to try to help make the environment safer and more friendly and more inviting, but we may be entirely wrong. But how do we get that comfort to try to improve it? Because you know, we've all done years of training, and it's not easy for us to necessarily go and say, I'm going to go and learn how to do social psychology and behavioral psychology like you've done.
You know, I'm sure in Canada, like there is in Australia, a great movement towards consumer participation in health services, that consumers of services sit on various levels of health decision-making boards, at policy level, at programmatic level. So being able to institute those processes and draw on those people's experience as consumers of services to ask the questions, what's working here and what isn't, is a really powerful tool. That, of course, needs to be done well, that it's not a tokenistic involvement because, you know, garbage in, garbage out type scenario. But being able to implement those formal policies that are respectful and genuine and engage in a real discussion to give you the insights that, yes, I agree, you know, and myself as a person who doesn't share that experience also has to learn slowly and with a great deal of humble pie sometimes.
Okay, Dr. Page wants
Just
one
a
quick
little
question.
teeny
It's gonna
question.
be-
I'm really moved by your talk. I'm from UC San Francisco. Carla, there's the other side of the equation. We reach this equilibrium. People trust us, and the staff is working well. But then something happens, and the staff feels so violated when the clients do something really stupid, and put an unborn child at risk for no reason or for this or that. And then I'm dealing with sort of other damage down the line. Have you studied any of that also?
No.
Because
That's a big
because
question.
developing these great models, you think you're going to reach this place, but the truth is there is a give and take, and then there's the jadedness comes up even in the staff, and so we're constantly having to deal with that
This
too.
is where I think a consumer who is able to give advice to staff, who's able to debrief with staff, to able to reset policy and practice, to keep morale high, would have much more important things and insightful things to say than I will ever have.
Thank you very much.